Welcome to another Journal Club session. I hope you enjoyed last month's topic that looked at the use of locally prepared peritoneal dialysis fluid for acute peritoneal dialysis in children and infants in Africa. If you missed it, don't worry. You can always access it through the YouTube channel. Are you watching this alone, or have you gathered a group of colleagues to watch it with you? If you are alone today, maybe consider watching with colleagues next time. You can access a guide how to organize colleagues watching together in the description section below. This month's article is all about assessing and addressing the problem of pain and distress during wound care procedures in pediatric patients with burns. It was written by van der Heijden et al. And published in the journal Burns in 2018. Let's first look at the graphic summary of the article. This graphic breaks down the different sections of the article and provides a visual summary. In this video, we will now unpack each section. If you have a copy of the article with you, you could track the sections of the article as I speak. We start with the introduction that you can find on the second page of the article just below the abstract. The trauma of a burns injury is associated with pain and distress. Pain is caused by both the injury itself and by intense procedural pain related to wound care. Burn injuries have been associated with post-traumatic stress. In children, pain intensity and distress are highly correlated, which means that as pain increases, the child becomes more distressed. Furthermore, if pain is not managed, the child is more likely to be distressed for current and future procedures. Wound care of burn injuries involves removal of dressings, cleaning or debridement of the wound, applying wound care products and new dressings, all of which are painful and frightening. In high-resource settings, children have expressed moderate to severe procedural pain during burns wound care. Before this study, there were no baseline measurement of pain and distress in children from resource-limited settings, which led the authors to conduct this study in South Africa to assess the extent of pain and distress in children during burns wound care. We now move on to the methods section of the article, where the authors explain how they gathered their data. You can find this on the second page of the article, right after the introduction. This was an observational study to measure pain and distress in children undergoing burns wound care. An observational study observes or looks at people's behavior in the environment that it typically occurs. The study took place at the Pediatric Burn Unit of Red Cross War Memorial Children's Hospital in Cape Town. Children were eligible to participate if they were newly admitted patients of all ages receiving their first or second wound care procedure after admission. Outcome variables were pain intensity and distress during wound care, measured with the Comfort B scale. When observers use the scale, they consider the intensity of 6 behavioral manifestations: alertness, calmness, crying, body movement, facial tension, and muscle tone, rating each on a scale from 1 to 5. Scores are added up with possible totals ranging from 6 to 30, with 6 to 13 representing mild pain and distress, 14 to 20 moderate pain and distress, and 21 to 30 severe pain and distress. Information about the child and most recent medication was also collected. Prior to wound care, the parent and child, if older than 7 years, were asked for informed consent or assent to participate in the study. The primary investigator stood at the back of the room, observed the child, and took notes. For example, was a pacifier or dummy given? The investigator used the Comfort B scale to assess pain and distress during the 4 phases of wound care. Moving on to the analysis and results, which can be found on the third page of the article. Just to note that this study is part of a bigger randomized controlled trial that measured the effects of live music therapy on pain and distress after the wound care procedure, but that study is not reported here. Descriptive statistics were used to summarize the background of patient characteristics and included gender, age, language, details of the type of burn, as well as details of the dressing. These are summarized in Table 1 on page 4 of the article. Other tests included correlation tests, the Mann-Whitney-U test, as well as multivariate regression analysis to see what factors were identified as the greatest association with pain and anxiety, as measured by the Comfort B scale. Results were generated by statisticians who performed these tests using a statistical program to find relationships between variables and the outcome of pain and anxiety. So what did they find? There were 124 children in the study, of which 64 were boys and 60 were girls. The median or middle age was 21.2 months. 90% of the burns were scalds, and the median or middle total body surface area was 8%. The mean or average Comfort B score before wound care was 11, which equates to mild pain and distress. 6 types of analgesics and sedatives were given. You can have a look at these on Table 2 on page 4 to see the doses and the number of minutes before the wound care that the medication was given. Analysis of the Comfort B scores revealed that the median or middle pain and distress scores were 24 during removal of bandages, 25 during washing, and during application of new dressings. The median score decreased to 22 when bandages were applied at the end. All these scores are severe pain and distress. The box plot in Figure 1 on page 5 illustrates that range of Comfort B scores at the 4 different phases of the wound care. The vertical black lines represent the range of pain and distress scores, highest and lowest. The box represents where half of the scores were, also known as the interquartile range. The horizontal black line in the box represents the middle score, and the dots represent the number of children that fell outside of this range and what their individual scores were. Table 3 on page 5 provides a breakdown of how many children had mild, moderate, or severe pain and distress at the various time points in the wound care. Continuation of the results of Comfort B scores on page 3, the second column, explains the results of the regression analysis, where the aim of the analysis is to determine which variables are most likely to be associated with pain and distress. The statistical test in this study showed that only the age of the child was associated with pain and anxiety, not total body surface area, not the time since burn or the time since the last medications were given, and not the gender of the child. The younger the child, the more likely they are to exhibit pain and distress. Which brings us to the conclusion. This study reports on the level of pain and distress in children undergoing burn wound care, without parents present and without any form of distraction. In the setting of this study, parents were not permitted to be present because it was considered too stressful for the parent, the child, and the nurses, and there is a lack of resources to support the parent and the child during or after the procedure. The children in the study displayed severe pain and distress in all stages of wound care. Although the children received analgesics and/or sedatives, the timing of the wound care was not based on when the medication was given. The authors made several recommendations for future research, which included to explore distraction techniques like music, videos, and parent involvement on child pain and distress during burn wound care, to assess if pain and distress increase or decrease over time, investigate pre-procedural support for caregivers and children older than 4 years of age, to explore ways to include parents before, during, and after wound care. Some of the implications for practice and policy include that clinical staff need to be aware of the painful and distressing nature of burn wound care, particularly in younger children. They also need to consider ways to alleviate or address this pain and distress and apply it to practice. We've come to the end of the video, and so now you need to access the article. The link is in the description box below, or maybe you already have a printed copy. We really encourage you to read the article in full, recognizing the parts that we have just summarized for you. After you have done that, consider the reflective questions here on this slide. If you are watching with colleagues, discuss your answers between you. Following that, take a moment to think about what you have learned and how you could apply it to improve nurse practice in your setting.